And hello, good evening, all of you out there watching from Malaysia. And I think there might be some folks watching from the US. So, good morning to you. With me today, and I'm very, very pleased and privileged to introduce my friend and longtime DOBS member, Dr. Khoo Kim, who is now one of our US diaspora. He's a consultant endocrinologist at MercyOne. And how do you pronounce it,
Des
Tekim?
Moines. Des Moines.
Des Moines. Des Moines. Des Moines. And he's an adjunct assistant professor of endocrinology at the Des Moines University as well. So, Tekim, how are you?
I'm good.
And
I'm good.
you told me a bit earlier why you're not that good. Maybe you want to share with the audience what happened to you yesterday.
Well, yeah, it's for one, it's we are 14 hours behind Malaysia, so it's 6 a.m. here right now. So good morning or good evening to all of you. But I guess fortunately for me, I got my second Moderna COVID shot yesterday. So as many of you probably have heard, some people apparently do have more symptoms, flu-like symptoms with the second shot. So that seems to be the case for me. But still 100% in support of the vaccine program.
Yeah. We are just waiting for it to arrive. So, probably early March for us. But I'm glad you got it. And hopefully things will get back on track in the US.
I think
after what we're just watching.
Good news.
Good news. Same here in Malaysia. Cases are just going up, and the public health system is actually really needing a break. Especially our frontliners. But anyway, we instead of talking about vaccines and COVID, we are talking about something different, which is right up Tekim's alley, which is on diabetes. And Tekim will be talking to us on insulin pumps and glucose sensors. So I just want to go through some housekeeping. Now, as usual, we are going to use Slido for questions and answers, which we'll leave towards the end of his presentation. To join us in Slido, I'd like you to go to slido.com and enter I think the code, is it correct? Yeah, hang on a sec. 7391, yeah? 7391. You can also use your barcode scanner or camera app if on Apple, and then the scan that will take you to slido.com and to the Slido page. All right, we just want to warm up a bit. So to get you used to Slido, we'd like to know who's watching. So if you guys can get on Slido right now and tell us whether you're a GP, medical officer or resident or house officer, or whether you're a specialist or other, including retired doctors, admin, and so on. So this is just to get you onto Slido and also give us some feedback. And a couple of other poll questions I'd like to provide Dr. Khoo some idea of who's watching as well. Some poll questions he wants to ask. Okay. Can we have more? Yeah.
Still early.
Still early. Yeah. No,
my wife
people
and
are
kids are still sleeping.
Yeah. It's now 6 a.m. for Tekim. It's 8 p.m. in Malaysia. 6 a.m. for Tekim, and he's an early bird. He tells me he gets up at 5. Yeah. For me, I'm even earlier, but it means as you get older, Tekim, I wake up at around 4.
The problem is for me, I go to bed at 8 p.m. sometimes, so that comes with age too, I think.
I have to get to bed by 9-ish nowadays, because if I wake up at 3, that's it. I don't go back to sleep. Okay, 14, about half GPs, half specialists, and half medical officers, and so on. No retirees watching. Okay, all right. Bit more GPs, yeah. 1 or 2 more votes. Maybe can we hit 20?
Come on, guys.
Yeah. The trouble is some are watching with a mobile phone. I already tried to publicize that when you're watching webinar, try to use a large screen device like an iPad, tablet, laptop, or desktop, And then when you're on it, then you can use your mobile phone and get on Slido and participate in our polls and Q&A. And towards the end, we'll display the QR code for you to claim your CPD point. And again, you can't be watching with a mobile phone and then scan for CPD points with your mobile phone. Unfortunately, it doesn't work. So you have to be watching on something else and then scan for CPD points with your mobile phone. So it looks like there are a little bit more GPs now on the participant poll. One more, and then I'll switch to the next slide. One more, please. Yeah. Okay, we are stuck there. I don't think we want to wait. 20. Okay. Okay, half GPs, then specialists and medical officers. Okay. Right. Next one is this is a question which Tekim wants to know. Do you manage diabetes patients taking insulin? So just a simple yes or no. Just let us know. Okay. I don't know in GP practice here how many be using insulin in their practice. Maybe more hospital-based doctors, I guess. I'm not so sure, but my feeling is not many GPs will be taking on diabetics who need insulin in their management. So maybe that reflects the bit more yes than no. Okay. Half.
50-50.
Seems like it can't make up its mind whether it's 50-50. It's just nice to see how the Slido is actively moving up and down the bars. Okay, slightly more. Yeah, okay. Righto. And then next question is, have you had a patient experience severe hypoglycemia as defined by hypoglycemia severe enough that third-party assistance was needed?
So we actually define this not numerically, but clinically. So if someone's glucose, well, I'm sorry, I can't convert. How conversion is you divide it by 18, but if someone's glucose was say 40 milligrams per deciliter, but they're conscious, they are able to talk and treat themselves, we don't call that severe. Conversely, if someone's glucose was 50 milligrams per deciliter, but they were so confused that they couldn't treat or recognize it, they needed someone to guide them, we consider the second one more severe than the first one. So it's not really a numerical diagnosis per se.
Can I ask when is the US going to ever use SI units?
God knows. I train in Canada, and so in medical school we were using SI units. The roads were in kilometers, and then for my specialty, I moved down south to the border, and suddenly everything was different. I don't think it's ever gonna happen.
Very hard for us to think in milligrams and grams,
I know. It's kind of bad.
That's okay. So we've got a little over half who have experienced patients with severe hypoglycemia. I've got tails during my training days as a medical MO, and we've seen all sorts of strange behavior with apparently psychotic patients actually turn out to be hypoglycemic and so on. Yeah.
I mean, in my field, I've seen quite a few. I've had patients who are involved in unfortunately fatal car accidents because of hypoglycemia. So it certainly does happen, which perhaps the content of the talk will be more relevant as we go into it.
Sure. Okay. Anyway, thank you guys for responding. The questions will come on later after the talk. So stay on Slido, but before that, just want to let you know, we will display the QR code only right at the end. Now, for those who have difficulty scanning, I will entertain manual upload of points. We give chance lah in Malaysia, we say give chance. But you have to email me, ketua@docs.my, and then I will be saying 3 code phrases or 3 code words throughout the talk. I won't be displaying it. So you have to mention in the email what those code words. Okay, the first code word is code blue. Okay. All right, I'll just say it once. Or maybe I'll repeat it. Code blue. I will mention 2 others later. All right, and you just put it in the correct sequence. So it will be the QR code will be put in the space here. Okay, I will now pass over to Take Kim for his presentation. So I'll switch slides now. Yeah.
Mm-hmm.
Okay. So
Okay.
yeah.
And let me just get started here. So please let me. Can you see the slide? Okay.
Yeah, it's fine. I will switch to full screen mode now. So
Sure.
you guys will be able to, so you won't be able to see me and Take Kim, but the slides
Okay.
will be bigger. So for those of you who appreciate bigger, the font may be a bit small if your device is not that big.
Low far.
Go ahead. Yeah,
if you
go ahead.
screen.
Go ahead.
All right,
Yeah.
Alan, thank you for the introduction and the opportunity to talk this morning. I want to give a shout out to my colleagues on in Malaysia, my family, they're watching as well. So today I'm going to be talking about some of the newer options available to us for management of diabetes. Specifically, we'll be talking about glucose sensors or CGMs, as well as insulin pumps. I'll have to admit I've not used Slido before, so if I'm having some hiccups, Alan, please jump in and let me know you're not seeing this right. So
No, it's fine. It's perfect. Carry on. Carry on.
perfect. Okay. So disclosure, I am not paid by any device company. This is purely my view, my opinion. I'm not here to promote any single product. The second disclosure is I've never practiced medicine in Malaysia. I taught in medical school for a year, but I've never practiced clinical medicine there. So if I'm a bit naive about the procedures or what's available, please forgive me. And as we were alluding to just now, in the US, we do not use SI units. And so glucose, you will hear me talk about it in milligrams per deciliter. If you have to convert, you would just divide it by 18 to get to millimoles per liter. The other disclosure is if I'm slurring, it's because it's early in the morning here. Yeah, we are 14 hours behind Malaysia. So if I'm not making sense, that might be a reason. So just some background, as Elena mentioned, I'm from Malaysia. I'm a Saraman boy. I went to St. Paul's Institution, followed by A-levels at Taylor's College. At that time, it was in Subang. I went to IMC, International Medical College in '96. It was still a college then. It was still in PJ Old Town. I graduated from the University of Calgary in Canada. It was twinning with IMC at that time. And I did my specialty and subspecialty training at the Mayo Clinic in Minnesota. I've been in practice in MercyOne, Des Moines, Iowa for the last 13 years. This is a city in the Midwest, and it's a connected health system of 420 care locations with 20,000 employees. The main hospital has 875 beds, 30 operating rooms, and 2 helicopters. No one ever knows where Iowa is, so if you are wondering, we are in the Midwest. So Iowa is the state, and Des Moines is the capital of Iowa. Chicago, which you probably will recognize, is a good 6-hour drive away. We drive everywhere in the US just because it's so spread out. So the objectives today are several. The main intent of this talk is to go over the technologies. But before we jump into it, I think it's helpful to be reminded of the underlying pathophysiology of diabetes so that we can perhaps understand why we ask as much as we do from our patients when it comes to treatment as well as monitoring. We're going to review insulin pumps as well as glucose sensors, kind of go over its role and its limitations, because there's certainly many misconceptions out there about what they do and what they don't do. So first off, when it comes to glucose metabolism, we use glucose for energy. We use glucose to generate energy. The body requires insulin for glucose metabolism. And as you know, insulin is secreted by the pancreas, specifically by the islets. It's important to keep in mind, though, that the insulin secretion is continuous. You never make zero insulin. Even if a person is fasting, you are always making some insulin, and the insulin levels are meant to match the glucose levels. And when we consume meals, we see some postprandial hyperglycemia. And so the insulin levels are meant to follow the spikes in the meals. Alan, quick question. Can you see my cursor on your screen?
Yes, I can
Okay,
see the
perfect.
cursor move.
Okay,
Perfect. Yeah,
just
it's
making
fine.
sure.
Yeah.
Okay, so a fundamental thing to keep in mind is even when one is fasting, the insulin production never ceases. When it comes to type 1 diabetes, this is a condition of absolute insulin deficiency. A person makes zero insulin. It can be from a few reasons, but one of the more common ones is when we have autoimmune mediated destruction of the islets. So the immune system gets a bit overexcited. It seems to confuse the islets in the pancreas to be an invader, and it starts to mount an immune response, which over time causes destruction of those cells. When that happens, a person makes zero insulin. The body then is unable to utilize glucose to generate energy. So even if you were hyperglycemic, your sugars were very high, you are not able to use that to generate energy. So the body starts to break down fat to try to generate energy, which leads to ketosis. In fact, prior to the discovery of insulin by doctors Banting and Best in Toronto, type 1 diabetes, when it becomes full blown, was not compatible with life. Patients with type 1 would die within a few days or a few weeks. So patients with type 1 must be on insulin replacement. And this can be done in one of two ways. You can either give someone insulin injections, which still remains the mainstream. This is done by using a combination of long-acting insulins once or twice a day. We have options like Glargine and Detamir, which I believe are available in Malaysia. And at meal times, a person would inject a rapid-acting insulin like Aspart or Lispro. The other option, which is becoming increasingly popular in the United States, is by means of an insulin pump, a device which gives a person a continuous flow of insulin. Now, in contrast, type 2 diabetes has a few factors going on. There are several contributors. We all know about the so-called insulin resistance. This can be from familial factors. It can be from lifestyle factors, obesity, lack of exercise. In this case, the body is resistant to the actions of insulin. And so your islets have to work harder. You have to make more insulin to maintain normal glycemia. So your body is making more insulin to keep your sugars normal. The problem is, though insulin resistance is one of the initial factors, the other issue is this. We are born with a finite number of islets, the cells that are capable of making insulin. And as we age, like the rest of the body, there is some age-related apoptosis. We start to have fewer and fewer islets as we get older, just because that's how the body works. So with that hypothesis in mind, the truth is, if humans had unlimited lifespan, if everyone lived a few hundred years, everyone eventually becomes diabetic. In the context of insulin resistance, though, you are working the islets even harder. You are overworking the islets, causing the islets to burn out even faster. So a fact that is perhaps surprising to some of my medical students is that even type 2 diabetes, you have insulin deficiency. Unlike type 1, it's usually not absolute. You're not making 0%. You might be making perhaps 50%, but there is a degree of insulin deficiency for type 2 diabetes. So for that reason, many patients with type 2 initially may be treated with oral agents, but for many, insulin is eventually necessary. So this is a piece of background information we want to keep in mind. So we no longer necessarily see type 1 versus type 2 diabetes as two completely different entities. Instead, what many of us now do is we see them as on different ends of a continuous spectrum. Type 1, you're making zero insulin. Type 2, you're insulin resistant, but as you get older, you make less and less insulin. So the truth is, there is a lot of overlap between the two. Regardless of what you call it, though, it's important to keep in mind that the objective ultimately is the same. It should be the same, not giving it a name, but rather treating the glucose, keeping the glucose controlled to minimize the complications of uncontrolled diabetes, while at the same time, not over treating it to cause too much hypoglycemia. But a few things to keep in mind is a true type 1 patient should never be without insulin. And don't put off insulin treatment just because you're classifying it as type 2, because many type 2 patients eventually do need something stronger, more than what the pills can do. When it comes to insulin treatment, though, we have many different kinds of insulin, many different brands of insulin, quick acting, long acting, intermediate. But the most robust, the most physiologic insulin program, which is what we tend to do with patients with type 1 diabetes, is a combination of long and short acting insulin. We also call this the basal bolus insulin program, or the MDI, multiple daily injection program. In this case, a person is getting a shot of glargine once a day, as well as usually 3 shots of rapid-acting insulin to cover breakfast, lunch, and dinner. I should actually clarify, in the US, dinner and supper is used interchangeably. So I realized in Malaysia, supper means something completely different. Now, insulin works. That's the good news. The bad news is insulin requires a lot of work. Safe insulin usage is very labor intensive because these patients should be testing their blood sugars 4 times every day. The reason is, if you are talking about a long-acting insulin, which works over 24 hours, because it works over 24 hours, we tend to make adjustments to the insulin dose based on their fasting readings. So that's the reason why a person on glargine should be testing at the very least before the first meal of the day. If we are taking a dose of Lispro for breakfast, or Humalog here, it is meant to cover the spike of glucose that we see from breakfast. And so titration of the breakfast dose is based on what their pre-lunch numbers are looking like. So if a person's pre-lunch readings are typically running high, it tells you that perhaps the following week, we need to be raising their breakfast dose. If a person is taking a dose at lunch, we make adjustments based on their pre-dinner readings or pre-supper readings. And if you're taking dose at dinner, we make adjustments based on bedtime readings. So for that reason, 4 checks a day is usually necessary for a person on this kind of insulin program, especially for a patient with type 1 diabetes. A question I get asked a lot is, well, do I really need to do this every day? Answer is yes, because the body is dynamic. Our needs will change constantly. What works this week is probably going to change next week. So you cannot make assumptions that 5 units for breakfast will suffice every day for the rest of your life, especially considering in the US, we have changing seasons. And so here, classically, people get less active in the winter months. As right now, it's minus 13 degrees Celsius outside right now. So people are less active. But with illness, if someone puts you on prednisone for bronchitis or whatnot, it will also raise up blood sugars. And so patients need to be checking their blood sugars constantly. Now, picture this if you may. It's a lot of work. To check your glucose, you need to get your bag of toys out. You need to load up the lancing device, which is a spring-loaded device that has a small needle. You want to insert a glucose strip into the glucometer. So put this in there. You want to clean your finger with an alcohol wipe. You want to activate the lancing device, which makes a small finger prick, and apply that small drop of blood onto the strip. Imagine doing this 4 times a day, every day, for the rest of your life. And many a times, my patients might be testing more because we tell them that you should be checking 4 times a day, but you should be also testing more if you suspect you're hypoglycemic at that point of time. So it is a lot of work. It is very, very labor intensive. And so for decades, we have been waiting for a simpler modality that allows our patients to keep an eye on their blood sugars. So this is where we takes us to the next topic, which is the continuous glucose monitor. Now, the continuous glucose monitoring systems, or CGMs or CGMs, more commonly known as glucose sensors, they are now available, and I believe one of them was launched in Malaysia recently, and perhaps you guys might be more aware of this than I am. These are patient-operated devices that monitors the glucose continuously. So it is a boon for many of these patients. But we need to understand, though, that these devices are not checking blood glucose. Instead, they're checking the glucose level in the interstitial fluid, in the interstitium. So the clear fluid that you see coming out from a wound if you graze your knee. So it does take time for the glucose levels to equilibrate between the interstitium and the blood. Now, this is patient operated, so they apply this themselves. Usually, there is some sort of a spring-loaded applicator, depending on the brand. They would put it on a body part, often the arms, the back of the arms. They activate it. The spring will basically paste the sensor on their skin. It is held onto their skin by an adhesive, so kind of like a sticky plaster at the back. Okay, so this part stays on top of the skin. Part of it will penetrate the skin, and it will remain there for the duration of the sensor wear. This picture is exaggerated. It doesn't look that big. It's probably just about 1.5 centimeters long, and the thickness is not sure if you use monofilaments for diabetic foot exams, but it's about thickness of a plastic monofilament, so not really that thick. Once this is inserted, it does sometimes take time to warm up, but once it is warmed up, this is checking the glucose levels all the time. And the glucose levels are either transmitted to a receiver continuously. We call these real-time CGMs, or on demand. They are flash CGMs where the sensor is on them all the time. When they want to check the glucose, they would put a scanner near the sensor, which then reads the glucose reading at that point of time. Now, these systems have been really around for a long time. Even when I was in training, 16 years ago, they've been used. But the problem, though, is that the sensors have not been reliable historically. A few reasons. For one, they have not been accurate. They do not measure blood glucose. They measure interstitial glucose. So it's not necessarily a problem with the device. It's a problem of biology. The glucose is always going to be more accurate. The interstitium will always lag behind. Bodily fluids will always lag behind. The glucose is carried in the blood. It then has to seep out into surrounding tissue to reach a steady state. And so the problem is in dynamic situations where if the glucose is dropping or rising rapidly, these things can lag behind by quite a bit. The older systems also had potential for drug interaction, including the commonly used paracetamol. So in the past, if you were taking paracetamol for a fever, your sensor readings might falsely read higher numbers than the true numbers. So in the past, we've used these things really to supplement, but not to replace the glucometer. Patients still had to poke themselves 4 times every day, but they would wear the sensor in addition to kind of like a safety net, just to make sure that they don't drop their blood sugars too low in their sleep. They have something that's able to warn them if it's starting to drop. We've seen a lot of improvement over the last decade, though. We have more accurate systems. We have predictive algorithms that the software is able to predict where the glucose might be in the next few minutes, and the newer systems are not affected by paracetamol. So in the United States, we have several models available. We have the Dexcom G6 and the Freestyle Libre. We also have the Eversense and the Medtronic Guardian. I believe in Malaysia, the Freestyle Libre is now newly available. And from my research, I believe the Dexcom is available in the Asia Pacific region, but not necessarily Malaysia yet. These two are approved by the US FDA to replace the glucometer. So patients wearing these systems do not ever have to use a glucometer anymore unless they want to verify. It has the ability to replace the glucometer completely. So I'm just going to go into some of the features of the specific models. I'm not going to go into too much detail as I don't want to bore the audience. The Dexcom G6 is a device that is worn on the skin. I'm not sure how well the picture shows up, but this is the sensor portion. This is a portion that stays on the skin. This is just the applicator. Okay, so this is worn for 10 days at a time. And if you're wondering, yes, these devices tend to be waterproof. We don't expect our patients to not shower for 10 days at a time. So this is worn for 10 days, after which they will need to switch it out. This continuously transmits to a receiver, which can be a smartphone. And these things also work with smartwatches. So the beauty of this system, though, is patients wearing this might be able to see their glucose level just by glancing at their watch. The Dexcom has other features as well. It has the ability to alert users when the glucose is above or below a certain threshold, which can be a lifesaver. You know, if you set an alarm, if your glucose is dropping below a certain point, even if you don't feel the hypoglycemia, the sensor will warn you. It has the ability to wake you up in your sleep so that you don't have a severe episode in your sleep. You can actually share the CGM information in real time with family members, with friends. So if you live alone, family members would probably appreciate having the ability to track your glucose levels even remotely. These things are not cheap. These are in US dollars and the numbers always change. But if you were buying out of pocket, the receiver is close to $500. Transmitter is close to $400. And a box of 3 sensors, which will last a month, is $350 approximately. Though keep in mind that in the United States, most people will have health insurance. So health insurance will pick up a significant chunk of it. The Dexcom is available in Australia, New Zealand, Japan, Korea, and Hong Kong. I don't know when it will come to Malaysia, but it's certainly available in some countries in the Asia-Pacific region. Next is the Freestyle Libre, and I think this is the one that's available there. Came to the US market a bit late, only in 2018. I think it's been used in Europe for even longer. And this is applied to the arm and is worn for 2 weeks at a time. Put it on, stays on for 2 weeks. Unlike the Dexcom, which sends the readings to your phone or your receiver, to test your glucose with this device, though, you do have to take the scanner, which can be a smartphone, and you have to physically place it near the sensor. When you put it near the sensor, it captures the concurrent glucose readings. It also captures the trends over the last 8 hours. So it's kind of nice because you can wake up in the morning, scan yourself, you can see how your glucose usually trends overnight. But because this is not a sensor that transmits continuously, we call this a flash CGM. So I don't know if you recognize this picture, but this is Theresa May when she met with our ex-president, Donald Trump, for one of the meetings, and she was seen wearing a Libre. This is not quite as helpful for patients with very brittle diabetes, patients of mine who do not feel the hypoglycemia anymore. As you know, the longer you have diabetes, the less aware of the body becomes of hypoglycemic changes. So you might not have the early warning system. You don't feel sweaty. You don't feel like your hands are shaky. You might not know that your glucose levels are dropping until you pass out. So for those patients, this might not be as helpful because this doesn't preemptively warn you. You have to scan yourself to know that your glucose levels are low at that time. However, the Libre is a simple device and therefore a lot cheaper. So for most patients with health insurance, the cost of the Freestyle Libre is less than $2.50 a day. And again, these devices are approved to replace the glucometer. So it does negate the cost of the glucose strips, 4 strips a day, as well as the needles, the lancing device, the lancets 4 times a day. So for many people, when they transition from the glucometer to this, they find that the cost difference between the two is actually pretty close. Another device we have available, I should mention too, the Freestyle Libre 2 is the newer generation. This has real-time alerts, whereby if your glucose levels are low, it will warn you that your glucose levels are low. It doesn't tell you your readings, it just tells you your glucose is low, scan yourself now. The Freestyle Libre 3 is coming soon. We don't know when, but if you kind of follow the news, this does have some ability to transmit real-time glucose readings to the receiver. We hope it comes soon, but I suspect it's probably going to be another year or two before it comes to the market. The Eversense CGM is also something that is available. It's new in the US. It's been used in Europe for a longer time. It's the world's first implantable continuous glucose monitoring system. As you can see in the picture, this is actually the sensor itself. It's about a thickness of a pencil lead, a few centimeters long. This is actually implanted into the subcutaneous tissue in the arm. It's a very minor office procedure. We were the first in the state to start doing this. But basically what you do is you just anesthetize the skin, make a small incision with a scalpel, create a pocket underneath the skin, stick the sensor in using the applicator, and remove the applicator. The sensor stays here. It's a small incision, so you don't even need to put in stitches or anything like that. So once you're done, you just put steri strips and patients are good to go. So these devices stay under the skin for a few months at a time. In the US, it's usually every 3 months they have to come in, have the last sensor be removed, and a new sensor is placed on the contralateral arm. The version in the UK, which is seeking FDA approval in the US right now, it's worn for 6 months at a time. So this provides yet another option for patients. So the sensor is embedded under the skin. It is then the glucose levels are then transmitted to I guess it's picked up by the transmitter, which is then transmitted to a smart device. Regardless of which device a person uses, these CGMs have a few features that are common. Not only are they able to see glucose readings pretty much in real time and make life a lot easier, these things have software that allows patients or doctors to generate reports looking at daily trends. For example, this is a report over a 2-week period. It tells you that for this patient, the 2-week average was 192 milligrams per deciliter. And again, to convert to millimoles per liter, you divide it by 18. You get to see the standard deviations, what the average was, and the variability. So in this patient, for example, there is a hint that, well, something's going up here in the mid-afternoon, and this is probably an issue with the patient needing more prandial insulin with lunch. Some programs, if glucose patterns are identified, the system may even suggest adjustments to the patient. So in this case, this is an older Dexcom report. It said, well, lows were found between 430 and 650. The patient may consider making some changes to the basal insulin and so on. So these things can be quite helpful. It allows for remote monitoring of glucose trends. Many of these have cloud-based software. For example, we use the Libre View for the Freestyle Libre and Clarity for Dexcom. And this almost allows for real-time diagnostics. It allows providers, doctors to be making insulin dosing recommendations remotely. And with the pandemic in my clinic, we've been doing telehealth pretty much 100% for the last 10 months. It's actually a boon for us because I have patients who live perhaps 2 hours away. And I'm able to download their glucose trends over the last 2 weeks. When I see them on Zoom, for example, I can see exactly how they've been trending almost right up to the last few hours. And if I see a problem with their glucose trends, I'm able to make adjustments to their insulin dosing on Zoom from 2 hours away. So benefits are obvious. It's a huge convenience. Again, thinking about the patient who has to prick himself or herself 4 times a day, every day for the rest of his or her life. You have sensors now that can potentially make that all go away. This is a huge boon. All endocrinologists will tell you, we have all seen patients suffer from severe hypoglycemia. I've had patients had seizures when they were driving, gone to bad car accidents. I've had a few patients over the years die from hypoglycemia. I just lost a patient last week to diabetic ketoacidosis. And so having a glucose sensor that allows them to track their blood sugars a lot better, a lot more easily, can certainly prevent severe hypo or hyperglycemia. Probably won't make it go away completely, but hopefully it provides patients with an early warning system that will help them nip things in the bud and prevent severe complications before it happens. When used correctly, these may result in improved A1C control without causing more hypoglycemia. I would say the main barrier is probably cost. Dexcom, as I showed you, is pretty pricey, even for Americans with healthcare insurance. The Libre is a lot cheaper, but still the cost is substantial. I do not know how much this will cost in Malaysia, but I'm very hopeful that they will make it affordable to most mainstream patients. There are also misplaced expectations. Some people think that, well, I slap a sensor on my arm, the diabetes will get better control. Not really. The sensor doesn't do anything about the diabetes. It just gives the patient more data. They still have to decide what to do with the data. So some patients don't realize that a basic principle of insulin use is self-adjustments. If they see trends, they should be making changes to their insulin doses every few weeks. Sometimes it backfires. It leads to data overload. Some patients' graphs and standard deviations and medians get a bit overwhelming. So sometimes they don't know what to do. It leads to meltdown. And paradoxically, it sometimes leads to insulin overdose. We need to keep in mind, for example, rapid-acting insulins will work for 3 to 4 hours. You now have a system that makes it so easy to check your glucose. Some patients tend to check their glucose constantly. So let's assume someone has lunch at 1 p.m. This patient is giving himself 5 units of aspart at 1 p.m. At 1:15, he's like, well, I'm just curious to see what my sugars are doing. I'm going to scan myself. Because remember, you don't have to use an actual strip. You don't have to prick yourself. You just have to wave your scanner on your arm. So he scans himself at 1:15 and realizes, oh, my glucose is even higher. Well, I'm just going to give myself another dose of aspart. At 2 p.m., he scans himself again. The glucose is still high. He gives himself yet another shot. And so we call this phenomenon stacking of insulin, not realizing that your initial 1 p.m. dose is going to be working until 4 p.m. You give yourself a dose at 1 p.m., 1:15, 2 p.m. The insulin accumulates, and it may sometimes lead to insulin overdose, leading to postprandial hypoglycemia. So patients wearing sensors, we do have to remind them that you want to give it time. You don't want to be stacking the insulin doses too close together. But overall, I think these sensors are a godsend. If cost was not an issue, my personal bias is all patients on insulin should be using a sensor. The glucometer, many of us are of the view that the glucometer is becoming obsolete. The limiting factor is obviously cost. In this next section, we're going to talk about insulin pumps or continuous subcutaneous insulin infusion, also called CSII. I don't think pumps are popular in Malaysia yet, but the last trip back, I was actually in touch with a Medtronic rep. I was surprised to find out that insulin pumps are available, but I think the cost is a limiting factor. They have been around for a long time. Picture on the left, this is the first experimental insulin pump, size of a backpack and connected by all kinds of tubings to the subject. Over the last few decades, they have evolved from something this big to something the size of a pager, something that you can clip on your belt. These are battery-operated devices that provide insulin without the need to inject yourself several times a day. These are connected to the patient by means of a tubing system and infusion set. So this is the pump clipped onto your clothing. There is a small reservoir of insulin depending on the pump. It may carry 200 to 300 units of insulin in the reservoir. And there is a small kind of a device here that starts to pump the insulin through the tubing. The tubing is connected to the patient by this infusion device here, which is, as you can see in this picture, you have an adhesive which keeps it stuck to the skin. and a small indwelling catheter. And so the insulin is coming through the tubing and it's being infused to the subcutaneous space through this small space here. There is also a brand called the Omnipod, which is actually a tubeless pump. So instead of needing to mess around with this is a pump and infusion set itself. The pump itself is stuck onto the patient's skin. So there's no tubing system and it's controlled by a remote controller. The infusion sets or the Omnipod pump needs to be changed every 2 or 3 days. Once the insulin reservoir is depleted, they need to put a new one on. So what these things do is they provide a continuous slow infusion of only a rapid acting insulin. So patients using this system, they do not need to be using glargine or detamir. They do not need to be using a long-acting insulin. Instead, by giving a person rapid-acting insulin round the clock, the pump is able to take this insulin and make it work like a basal insulin. So they have a basal setting, a basal rate that goes all the time. And when the patient eats, they need to count their carbohydrates, their estimates of how many grams of carbohydrates they're going to consume. And they need to program that. They need to punch that into the pump. They'll need to tell the pump, I'm eating 15 grams of carbs for breakfast. And based on preset settings, the pump will then administer a bolus to cover that meal. So by using a pump, you're using a single insulin to play the role of the long and short acting. Now, we use a pump for type 1 and type 2 diabetes on insulin intensive programs. But because the reservoir of insulin is small, even if you choose to use it for a type 2 patient on insulin shots, it's probably best reserved for people who are more insulin sensitive. I don't know how severe the insulin resistance is in Malaysians, but I can tell you that for my type 2 patients, I have patients taking well over 500, well over 1,000 units of insulin a day. So those patients would not benefit or do too well with these systems. When it comes to the pump, though, it makes the work a lot easier, but patient compliance is vital. Patients still need to be testing their glucose. They do need to have the ability to count their carbohydrates and to operate the pump. Because these systems are not completely autonomous, there is a lot of work involved. But fortunately enough, the newer systems have the ability to sync with the sensor. So they are now pumps that talk to the sensor. What are some of the advantages? Well, overall, comparing patients on pumps versus shots, there might be overall slightly better control of A1C if the patient is willing to work at it. It is certainly a lot more convenient because instead of needing to take your syringe, your insulin out, draw it up, give yourself a shot if you're having a meal at a restaurant for lunch, you just discreetly pull the thing that looks like a pager from your belt, just tell the pump, okay, I'm eating this many grams of carbs. The pump is able to give you a bolus without you needing to physically inject yourself. The pump will also do some of the calculations for you based on preset ratios. The pump will also remember when the last dose of insulin was. So the situation of insulin stacking that I mentioned earlier, these pumps have a built-in feature. The pump will remember if you ate lunch at 1 and you're trying to bolus again at 1:30, the pump's going to say, whoa, you still have 3.5 hours of insulin still working. I'm going to give you less than what you want. The other benefit is the flexibility in basal dosing. If you think about a traditional basal insulin, a person on glargine 24 units, for example, you get the glargine here, it's going to be in your system for 24 hours. You can't make the glargine work better in the morning versus in the evening. It's got a 24-hour, pretty much non-peaking insulin. So it's in your system for 24 hours. But some people have unique needs. For example, the obese patient with severe sleep apnea might have an exaggerated dawn phenomenon where you might run higher, say from 2 a.m. to 6 a.m. And so that patient might need a basal insulin that works a bit better in the morning versus the rest of the day. And so by using a rapid acting insulin infused slowly through the pump, you can actually pre-program different rates. In this example, The pump gives 1.05 units per hour of insulin from 1 a.m. till 3 a.m. From 3 a.m., it gives 0.9 units an hour. From 6 a.m., it's 0.85. So the pump is able to modulate your basal rates as needed. And if you think you're going to go run a few miles on the treadmill, you are able to set a temporary rate reduction for exercise. So using the pump has been shown to improve the quality of life. Disadvantages, well, main one is going to be cost. These things are not cheap. Again, these are in US dollars. Up to $8,000 for the device, $400 a month for supplies. With the health insurance, you probably will get a chunk of it covered, but what's left for you, your out-of-pocket will still be substantial. Some people just don't like the feeling of being attached to a device all the time. It does pose an occupational hazard. If you have a factory worker wearing something on your belt with kind of a small tubing running around, there is a chance things might get kinked, get caught, and so it can be a bit tricky. Pump users have a higher risk of diabetic ketoacidosis as well, because you don't have a long-acting insulin in your system. You're using a rapid-acting insulin infused continuously. So if there is a pump malfunction or an insulin infusion site failure, for example, something got kinked or the tubing got pulled out, these patients go into DKA a lot faster. But perhaps one of the bigger barriers I see is misplaced expectations. People think that insulin pumps are better than shots. People think that once they get on a pump, they don't need to do any work anymore because it will do all the work for them. Not really. Studies have shown if you put a wrong patient, the non-compliant patient, on an insulin pump, there is a good chance that the diabetes will be even worse. The A1C will probably get worse. So the reality is the pump is not completely automated, and it's not meant to necessarily do things better. It's just a different way of doing things. It does demand a lot of work from the patient's part. Most studies comparing the pump to shots show only minimal improvement in the A1C. What we are starting to shift to the next stage of evolution for pumps is what we call the closed loop systems. These are starting to come into the market. They are not foolproof yet, but we're getting there. These are systems that comprise of a sensor that is accurate enough to rely on without the need to use a glucometer, and pumps that communicate with the sensor, and systems that can automatically make some adjustments to the insulin rates without patient input, because the current systems require a lot of patient input. So if the patient is completely non-compliant, it's not going to work too well. So these systems are ideal because the pump can detect in your sleep, for example, your glucose levels are going down. The pump can automatically lower your basal insulin rate without any input from the patient. The problem is there is still much that is required from the patient. Patients, at least with the current systems, they still need to count their carbohydrate intake at meal times because the mealtime boluses are still done manually. Some systems do still require a confirmatory glucometer reading. If not, the system might kick you out of automatic mode and go back to manual mode. So whichever system you pick, it's highly, highly dependent on the patient. The brands available in the US market, we have the Medtronic, the Omnipod, which is completely tubeless. So this is a pump. This pump itself is actually disposable. Once you've depleted this, you toss it and put a new one on. We also have the Tandem T-Slim. I believe Medtronic is available in Malaysia, perhaps not the 770G, but the Medtronic pump, I believe, is available in Malaysia. Now, connected pumps also allow doctors to review trends and usage remotely. So again, in times of telehealth, I'm able to see my patient's glucose readings, the sensor readings, almost in real time. I can see how many grams of carbohydrates they were eating and the boluses they were getting. So in this situation, I'll probably see, well, whatever bolus he's giving for breakfast here is a bit too much because it's dropping the blood sugars. So many options. Ultimately, which brand to consider, I tell my patients, is like buying a car. So patient choice, many factors to consider: price, what the insurance preference might be, amount of insulin, whether you want something that is waterproof or tubeless or whatnot. But we need to keep in mind, though, that although we have pumps available, the shots remain the gold standard. So even if pumps are not yet mainstream in Malaysia, or even if my patients here can't afford a pump, they should not be seeing the insulin injections as inferior to insulin pumps. Insulin pumps are not necessarily a better way of giving insulin. They are merely a different way of giving insulin. There's an asterisk there because the newer systems might change that, because as systems get more and more automated and they take the patient out of the equation, it might be able to cope with even the non-compliant patient. So can't summarize, there are newer systems available to monitor and treat our patients. These systems do significantly minimize the disease burden, but it may only minimally improve the control of diabetes. The pump is available. It is a convenient alternative, but not considered a necessity. And I think that's it. So I think we should have time to take questions. This is a picture of my wife and my 2 daughters. And I'm sorry we will be missing Chinese New Year in Malaysia this year. So I hope to connect with some of you in person once this pandemic is over. But in the meantime, please stay safe over there. I'm going to stop my talking and let you guys ask your questions.
Okay, thanks very much, TK. Let me stop the screen share and let me switch to Slido. Right. Okay. Now, this is where you guys can answer your question. But before you answer your question, let me give you the second secret code phrase. All right. For those of you who can't scan for points, you can ask for manual upload, but you have to tell me what the 3 secret phrases are. So the second secret phrase is code red. Okay, I'm going to say it again, code red. All right. So please do ask TK your questions about pumps and sensors. I mean, you guys are so fortunate. There's so much choice in the US. Even though it's pricey, insurance pays. They don't have to put up so much copay, you know.
I think it's kind of nice that we have these options, but the truth is, the system here is a bit messed up in that the insurance companies often dictate. I think insurance is becoming popular in Malaysia, so I hope it doesn't get there. But my patients might want this brand, but their insurance will not cover it. They are supposed to use only this brand, so it's becoming somewhat of an issue. Now, I see a question there. Can the sensor be placed in a less conspicuous area, for example, the abdomen or the chest? It depends on the sensor, but these sensors are meant to be, the sensor catheter is meant to be in the subcutaneous space. So obviously the chest, I don't think you're going to have too much subcu space there. But it also depends on the brand. For example, if you're talking about the Dexcom, if you can find subcutaneous fat, anywhere goes. You can put it on the abdomen, you can put it on the back, you can put it on your arm. But if you are talking about the Freestyle Libre, this one, this is approved only for use on the arm. The Eversense implantable sensor, the one that goes under the skin, that is also approved for use only in the arm. We tend to alternate arms back and forth every 3 months. So it really depends on the brand itself. Now, truth be told, I have had patients who use the Libre in other places, and they tell me it seems to work okay. But in the US, we often defer to what the FDA has approved the device for. So, medical malpractice is a big thing here. So if the FDA says use it only on the arm, we're not going to say put it somewhere else. The other question is, what is your opinion on the new wearable sweat glucose smartwatch? I guess I'm not aware of a whole lot about this because these are not yet FDA approved options. They are not something that is used in clinical practice. I sincerely hope they will come to the market. But I have to say, part of me is a bit skeptical that these will ever come to fruition. I'm skeptical that they will ever be used in a real clinical setting, because although the technology might come, we have to understand that you can't overcome biology. When I'm seeing patients with diabetes, I want to see an accurate way of measuring glucose as close to real time as possible. And so if you're talking about something that's measuring glucose content in sweat or years ago, I remember reading an article about Google coming up with contact lenses that measure glucose in the tears, in your tears, and if your glucose is high or low, it can actually flash visual cues. It sounds great in concept, but if your glucose is rising rapidly, or if someone overdosed on aspirin and the glucose is dropping rapidly, how quick is it really going to show up in sweat or tears or other bodily fluids? I'm a bit skeptical that it will ever be accurate enough to be used in a clinical setting. Maybe for a personal setting, kind of like your Apple EKG or smartwatch thing, it might be helpful, but in a clinical sense, I don't know. Now, another question here is, how are we going to get patients to use sensors when having a glucometer is a rarity? And I'm sorry, this is what I was alluding to. I don't know how things are in Malaysia, whether glucometers are mainstream. So I guess I don't know how to answer that. But I think if you're trying to sell to patients, not literally, but if you're trying to encourage patients to check their glucose, though, the concept of not needing to prick yourself and squeeze blood out 4 times a day, a concept of just putting something on your arm that'll stay on for 2 weeks, and then just taking a scanner and just scanning like that, I think it will be an easier sell to patients because it's a lot more acceptable. Now, cost is going to be the issue. I don't know how much this is going to cost. And I did try to email our local Abbott rep here to give me some local contacts in Malaysia to get an idea of pricing, but I have not heard back. I hope these things will be affordable to the Malaysian public, but I guess I don't know.
I don't think it's fair to say glucometers are a rarity. I mean, almost you can buy them in every street pharmacy,
I guess maybe I should rephrase. Are patients using it though?
Yeah, rarity whether using it properly. I think if they're well educated and they I think our patients actually do. It's just a matter of motivation and thing. But I think some patients also love new gadgets. I had one Japanese patient who was proudly showing me his Freestyle Libre.
Mm-hmm.
He was on and showing how he could monitor his sugar so well. So I think it's some people would appreciate the ability not to have to prick themselves so often. And I think it's a matter of time and cost wise. I think if they market it right, it might take off. Though, as I was sharing with you, as you know, in Asia, there may be copycats or other manufacturers.
Yeah, you had sent me the link. I was quite fascinated by that.
Yeah, some other manufacturer, perhaps in a big country further north than us, might come up with a cheaper version. And the holy grail, I think, is actually non-invasive glucose monitoring. I mean, if the big boys like Apple and Samsung do have their next version watch, and there's rumor that the next Apple Watch may have glucose sensor, or the next Samsung watch may have, but I think maybe not for measurement of levels, but maybe trending. TK, what do you think? Just trending, maybe.
I think that's very helpful. Definitely. But I guess I should also mention, though, whether you're talking about glucometer or sensors, I find that it motivates patients a lot more if you can get them to understand that the checking isn't for the doctor, because when it comes to insulin users, we always emphasize you make the changes yourself to your insulin doses based on what you see a week at a time. So if patients realize that, oh, well, I'm not testing for the doctor to tell me what to do, I'm testing so that I can guide my dosing every week if necessary, I find that if they understand this concept, they are more motivated to test, whether it's with a sensor or a glucometer. Sometimes it's a bit difficult because I think there's also a generational mindset in that my older patients will say, I don't care to make changes myself. You're the doctor. You tell me what to do. I will do everything you say. The younger patients will say, okay, I will experiment and make changes. And that's the ideal situation.
Okay, there's another question about type 1 diabetes.
Yes.
Do you give metformin to increase insulin?
The standard answer is metformin is not FDA approved for type 1. So do it at your own caution. But the short answer is yes, I sometimes do. Metformin really doesn't increase insulin sensitivity. It's kind of a misconception. What metformin really does is it blocks release of glucose from the liver. As you know, the liver stores a lot of glycogen. If you stress the body out, especially in, say, bad sleep apnea, the body can release glucose even if you're not eating, causing your numbers to go up. And so I do have patients with type 1. But over the years, they become obese, they develop insulin resistance, as well as some other changes that we see in type 2 patients. And so in those patients, yeah, I sometimes cautiously do use metformin with the insulin. How does the glucose sensor extrapolate the interstitial glucose to the blood value? Well, this is where there is some difference. There will always be some difference. In fact, even across glucometers, the FDA allows for a difference of 20%. So I'm sorry, I'm thinking in milligrams to a DL, but if you're talking about a person's glucose who is at that time 200, a 20% difference, you could actually see a variability of 180 to 220. So there will always be a difference between the sensor, and the true value. This is where we tell patients, if things are changing rapidly, if you just ate a big meal, use a sensor, but use your glucometer as a backup. How do you select suitability of patients for an insulin pump? Not easy for Malaysians to do carb counting. Yeah, carb counting is a bit tricky because it's not a perfect science. It's kind of a guesstimate. You know, we want patients that have kind of a rough idea of how much they're eating, but we realize that it's not going to be 100% accurate. But there are certainly easier resources, smartphones with apps that allow you to count your carbs. Yeah, you know, you'll find that in restaurants in the US, most restaurant menus will have some nutritional information. If it's not on the menu on the website, they will definitely have it. How do you select?
I remember one Singapore resource actually, which had some tables which tell you like one helping of nasi lemak is how many calories, how much protein, or one helping of Maggi mee or something like that, you know. So there will be references out there to help patients do carb counting. But I wouldn't be surprised if there's already an app out there.
Yeah. And for us, actually, many of our patients, we actually have them spend a lot of time with our diabetes educators so that they can kind of go over the principles of carb counting as well. Patient selection for insulin pump, like I said earlier, I don't see it as a superior device. It's an option. So the patient who is motivated, but also the patient who is, you know, counting his carbs, who is testing the glucose, who are able and willing to do, patients who are willing to spend the money on it, and probably patients who are not that insulin resistant, because patients who are very insulin resistant, they're not going to do well on a pump. In fact, using pump in type 2 patients, there have been some studies suggesting that the A1C doesn't get better, it might actually get worse when they go on a pump, probably because the pump can't cope with the insulin needs for that patient. And our reader had some information here. The Freestyle Libre for 14 days cost 282 ringgit. Wow. I don't know how much the glucometer strips may cost. Glucometer strips, I mean, if you consider this is going to take away 4 strips and 4 lancets per day, you know, I don't know how big of a difference would it be, you know, if you were to use a Libre for 14 days. But cost aside, though, boy, it is such a huge convenience. Sweating is not felt to, oh, go ahead, Alan, sorry.
No, it's okay. The next question, yeah.
Sweating is not felt to interfere with the accuracy because, again, the catheter is indwelling, it's under the skin. Some of my patients, though, if they sweat a lot, it might not stick, so it doesn't stay on for the 2 weeks. Some patients get creative, they get some Tegaderm or some other plaster and kind of slap it on, but it shouldn't interfere with the accuracy of the sensor.
And we nowadays can buy everything, medicines, medical supplies on our online shops, Lazada and Shopee.
Yeah, I've heard about it. So thank you for sharing that.
Ketosis prone type, yeah. Go ahead, yeah.
Well, I think this comes back to the overlap between type 1 and type 2. We always think type 2 insulin resistance, pills will be fine, you don't need insulin. But we do know that many type 2 patients will become insulinopenic over time, just because you live longer, you make less and less insulin. If you don't make enough insulin, you will go into ketosis. So I would say it's not necessarily tighter sugar control, but your choice, your selection of treatment. In this case, I would say this patient is should be on some insulin. Libre in ICU setting, conceptually it sounds good, but the problem with the Libre is that it's meant to be used in a personal setting, not a professional or medical setting. So we don't know about the accuracy. There's also been some concern that in a critically ill patient who might be hypotensive with perfusion issues, it might not be that accurate. So right now we are not using the Libre. I don't think we will ever use the Libre in an ICU setting. I have had quite a few patients, and my wife will attest to this because she's an anesthetist. Patients who are wearing a sensor, who are having some minor surgical procedure where they might be out of it for a few hours. Sometimes we tell them, just leave the sensor on and hand your reader to the anesthetist, and they can keep track of it. If there's any doubt, they will always do a confirmatory blood glucose reading. 24 to 48 hours to calibrate, that might be the old Libre. I don't remember. I think it was the first generation. I think it took about 12 hours to calibrate. The newest Libre, I think the calibration time, the warm-up time, I think it's just an hour.
Okay. Yeah. All right. I think we just have about time for. I mean, we've taken enough of TK's time with questions. It's now the moment they're waiting for, which is a CPD. But I'll mention the third and last phrase, and I've forgotten what the first two was. Already, you see, memory is short. The last phrase would be code white. Yeah, I think I didn't mention that, right? First two? No. Okay, never mind. We won't mention what the first two. You got to listen to the whole thing to catch those three phrases. If I repeated myself, just repeat the phrase and your email in the request to me in case you can't scan for CPD points. All right. So what I'm going to do now is to share with you the QR code for tonight's session. And I was, oops, I can't copy. Yes. Hang on a sec, I can't paste the code. Stop screen, pen fly. Oh, okay.
I can keep them entertained in the meantime. This is how a Medtronic pump looks. It's kind of the size of a pager. I don't know if people use pagers anymore. My medical students don't know what pagers are, but it's not that big. Infusion set. This is a set that needs to be changed out.
Yeah.
There you go.
There you go. This is the QR code. We have compulsory CPD now in Malaysia, and we're supposed to have 20 points every year before we can apply for annual practicing cert. But we don't have any MOC yet.
That's a good thing.
Is that a good thing? Yeah, we have to tell the academy that that's a good thing. Just for our annual practicing cert, but no MOC yet. Okay, let me check if the scanner works for me. So remember, you've got to have a separate device to scan. You cannot watch and scan with the same device if you're doing it on the phone. In the next generation MMA app, it may be possible. You could take a screenshot and upload to the app to claim your point. I've tried to make the QR code a little bit bigger as well. The other issue some of you might have with scanning is the MMA app sometimes get overloaded and then you get a spinning wheel. But I've managed to scan the code successfully. Yeah, I got the point. And I really, TK, thank you very much for spending your morning with us. And
no, I appreciate this opportunity. Thank you for asking.
And nice to see you, and I wish everybody well in the US. You've got great new leadership. I think it's everybody like a load has being lifted off your shoulders.
Yes. I think that's definitely we're feeling a lot more optimistic about the leadership.
Yeah, at least you got an action plan for COVID now, I think. And
Well, you guys stay safe there. I look
yeah,
forward to coming back to Malaysia. Well, probably not this or next year, but
yeah.
hopefully once this pandemic is over. I commend you guys for being on the front lines, for taking care of your
Mm,
patients. It's a tough time,
yeah.
but definitely, keep it up.
Yeah, we will just persevere. We will hang on. We'll wait for the vaccine to come next month. Sam Abraham, you can get the point if you can scan. There's Sam Abraham in Facebook is asking how to get a point. Just use your MMA events app, and then in the profile section, use the barcode scanner to scan for your point. This code will be valid for 1 hour. So to prevent abuse, the code will expire after round about by 10:30 or so. You'll expire Malaysian time at night. So
Okay.
if you have, yeah, I will have a bit of leeway. If you really have problem scanning, I will give chance in Malaysian lingo. You can email me to say you've watched the thing, you couldn't scan, but you still want the points. You must mention the three code phrases I mentioned throughout the talk. Okay. If you didn't mention, tak boleh lah. No point. Okay. Otherwise, everybody will say, I watched. How do I know you watched? And it's difficult for me to do this for the next 1 week. So for the next 24 hours, all right. So you have to give me some chance as well, all right, to get some rest. So okay, thank you very much once again, and
You are welcome.
yeah, have a great rest of the week ahead, and
You
to
too.
everyone, yeah, to everyone else, good night, and the video will be there still. You can continue to watch, and the code will still be active until around about 10 something tonight. All right. Okay, I'm going to end the broadcast, but Tekim will still be in the studio. I need to have a quick chat with you. Yeah.
All right. Good night, everyone.